Hey guys, I am Sebastian, and I thought I would do. Uh, I'm trying to do a couple YouTube lives, and hopefully this will help you guys with knee pain. So I'm here to answer any questions that you have. If you don't have any, then I'm just going to go over some topics that are related to knee pain and recovery. And um, this is something I'm going to try to do a little bit more frequently based upon some of the questions that we get from uh, our videos. And there seems to be a lot of confusion about how to recover from knee pain. And it's sad. I mean, like I have guys on my baseball team who have knee pain that just, end up not playing anymore. And so the first thing to realize when you're recovering from knee pain is number one is you figure out if it's surgical or not. Because a lot of people kind of they're worried about it being broken and they're worried about it being something that they have to repair. And so most of the time, the things that need to be repaired are things that would swell up dramatically, such as you were playing soccer and you landed, or someone kind of slid into you, and there was a pop and immediate swelling. And a lot of times it's a little bit more like ACL based, and sometimes if the ACL has been torn off the bone, it needs to be placed back on. Other things too, trauma-wise, a lot of times people find is that there's minor meniscal irritation or fraying or tears. And this freaks people out when they hear it. It's really not that big of a deal in the long term because meniscal injuries, a lot of times, in contrast to ACLs, they won't necessarily swell up immediately. It'll be delayed. It'll be like you kind of twisted your ankle a little bit or twisted your knee, and then like a day later, there was a little bit of swelling, not like a big amount. Typically, the swelling is a protective mechanism, so icing it is okay, but just let the swelling happen most of the time, uh, and it'll eventually desensitize the area. The whole point of the swelling is the body's trying to stabilize the area, and so going through and trying to stretch it out and so on is not necessarily advised too much when there's actually been an incident of an injury. However, most of the people, you just kind of wake up with it, or you squat too much in a day and there was no pop, there was no swelling, and um, or you were running and it started to become a little creaky and it popped up over time. That's all normal stuff, and most people are rehab cases until proven otherwise. And people in these situations, a lot of times what they really need is a good examination first, and I'll explain that in a second here. So a good examination is not necessarily an MRI, and it's not an X-ray. Although those are helpful, they're very helpful in figuring out if there's anything broken in there. But again, if things aren't broken, like in the two situations I mentioned before, like broken bones or torn off ligaments or large meniscal tears, and they're just extra information. And I know I've met a lot of people who necessarily they don't want to start their care until they see an image. And I think that's a big mistake that people tend to make. It's nice to know that there's nothing really, really wrong, but also too, you're stalling off on a lot of things you could be doing if you haven't just started traditional rehabilitation. A good rehabilitation program is usually what's needed for the knee, loading the hip and the ankle. A lot of times it starts with core work. This is all standard stuff, guys. Like, obviously, if you come to me or somebody else who practices a little bit differently in regards to coaching, you might get different exercises. Some of you might get clamshells, some of you might get quad sets, some of you might get, and it's all based upon what the person feels is appropriate for you, your age, your activity, and the type of problem that you have. There's not only one reason for knee pain. And that's a big misconception that people tend to have too, is they think that, well, my knee hurts and your knee hurts and that worked for you, so that'll work for me. And it's flawed logic, because you could have patellar tendonitis, I could have a meniscal tear, someone else might have a lot of sloppiness of the knee because of past ACL injury that was never addressed. Someone else might have had a car accident where they had their knee hit the dashboard and they've had their PCL tear. So there's a lot of different reasons for knee pain, and the exercise usually picks specific to what you're dealing with. Now, I'll tell you guys what I do typically when we find someone who's a rehab case, and there's I'll paint a picture of maybe a specific case, and we'll go over really what I would usually do in this type of situation, or at least first. If I mean, it might or might not work because it's all trial and error, really. But So say someone has pain kneeling down. They woke up with the pain in the front of their knee. They're about 30, 40 years old. They think it's maybe arthritic related because they're getting older. Maybe you had that you're fairly active, like you run or you play baseball or soccer just recreationally. So in these situations, if there's no gross swelling, a lot of times we'll stress test the knee. Stress test the knee requires, if you look at my finger here, if say we have this joint in question, we would load it into one direction, then the other direction, and then the other direction, and then the other direction, and then we twist it a little bit and we load it up. And so loading that area, basically what it tells us is if there's nothing provocative there and it doesn't piss anything off, then it means that we can safely load that joint. Or if it is painful in a certain direction, such as bending your knee forward, full bend versus extension, then we might exploit that extension in this case as a way to reduce knee pain. And a lot of times people will use things like end range loading the knee to do that, and it works out very well. But here's the basic thing that your rehab should kind of cover is again, once we're fairly sure this is not a surgical case, we need to shift load. And it's as simple as this. Okay, I'll explain it in a few different ways, but I want you to gather the idea of shifting load, because if you shift load, all of a sudden the possibility opens up of what exercises, of many different exercises we can give you. And so if you're a knee dominant squatter, I know squatting is a knee dominant activity, but if you really shimmy into the toes, like your heels lift up and so on, that's how you squat all the time. And it hurts to squat that way. Then we might shift the load into the hips with that movement. Okay. We might tell you to lift with your hips a little bit more, or we might do a bridging exercise to facilitate the glutes to help out, or get the hips to help out. And by doing this, what we're doing is we're shifting load away from an area that is sensitive or pissed. A lot of times the patellar tendon, in this case, these people with knee pain on the front with a knee dominant pattern like squatting, when their heels raise up, the patellar tendon doesn't like it. And so we're shifting load away from that momentarily to then integrate it back in. Usually over the course of a week or so, we will integrate that back in the form of just do that squat the way you did. There's not right or wrong way to squat if we're talking about a non-loaded squat. So go ahead and go onto your toes how you did squatting. We call them sissy squats if we're going to program that for therapy. And so in this situation, we're deloading the sensitive area in an effort to get it to feel better, to repair itself, because the body does repair itself, to chill itself out, to decrease the swelling, to decrease the irritation. And we're shifting that load into a different area. We could easily do it to the ankles too, or into the opposite leg via the exercise we pick or the therapy that we pick. But the important part here after that is to realize that we will put load back into it. It doesn't mean don't use your knee ever again. It means that you have to take it away for a moment and then put it back in. And putting it back in is the important part to be able to regain your abilities to play your sport, do activities again, is because at some point someone's going to tell you, yeah, your knee's bad, just don't use it. And that's going to be a terrible issue for you, because if you don't use it ever again, you've taken away what we call a movement option. If you can't bend your knee anymore, you're not allowed to, and I put something on the ground for you to pick up, what are you going to use? Hips, that's good. Ankles, that's good. Probably your back. And then you have a back issue. You have a back issue because someone told you don't use your knee again. Now, many of you will probably think, well, I can't use my knee right now. I know you can't because it hurts. But that's why it takes someone to get a little creative with shifting the load away to plug it back in later on. Okay. And so we have lots of videos on our YouTube channel for knee and glutes and hips and so on. And there's a lot of exercises that we've shown you guys. And so I want to encourage you to subscribe to the channel and just use the search bar that pops up at the top that will just put in knee pain or patellar tendonitis or meniscal tears or glute exercises or whatever. And you'll find a lot of things that you can probably look at and think, wow, these are good. These make my knee feel better. Obviously, you should be looked at because you want someone to stress test there and make sure it's not something that's surgical. but easily 9 out of 10 people are not surgical. Okay. We're very good at working with people with knee pain at Performance Place, and I think that a lot of you have probably tried already. We have a skin rolling exercise, which is on the page too. So the skin rolling one, all it really means is when it works, because there you'll if you read the comments, it'll say, "Wow, 10 years of knee pain gone with skin rolling. Thanks." Uh, what that basically means is there's a possibility this knee pain is coming from the low back, and if you help out the low back deload via again using the hips, and the knee will tend to feel better. Um, but what I hope it really shows you guys is that by something like skin rolling, if it helps you, then it's not probably your knee, because skin rolling is the skin and stuff under the skin, but it's not the muscles or the joint itself. And so try that video because it's a really inspiring one for a lot of people. There's a question. Cool. By the way, I guess when I go into these questions, just make sure that it say that disclaimer, I'm not your doctor, and go see your doctor first, but I will answer some things in here as we kind of say as a lawyer way. And then I'll probably close this for tonight. I was only going to spend 10 minutes on here. So I'm a 32-year-old male. My left knee hurts, especially when I'm going downstairs. I'm very active. I do hypertrophic training and do compound lifts like squats. Great. So in this situation, again, we're talking about a knee dominant activity bothers the knee. Going downstairs, I know there was a thing a while back where people said don't ever put your knees over your toes when you squat or any movement at all. And that's wrong. Because if you can't put your knee over your toes when you go downstairs, then you won't be able to go downstairs. You'll fall back. And same thing going upstairs. And so this is a perfect situation where maybe something like a movement assessment will help to figure out if you're loading your left knee too much, or you're loading your left limb too much. There's a case that we've seen, a case type that we've seen over and over again, where someone comes in with left knee pain, and you see that they're putting their weight onto the left side when they do a squatting pattern, meaning they're asking too much of the left side, and the knee and the hip sometimes takes the brunt of the force. And so it's easiest just to shift load away. In this case, a lot of times I'll have people do a glute priming exercise for the opposite side, or we have them do something called a banded bridge with butterflies, which is on our site too. And that one, it shifts load into the hips versus the knees. And so hypertrophic training is good for stuff, but remember, training for muscle mass is also it's a goal, it's an activity, it's a sport, and it's not necessarily therapeutic all the time. It can be. Compound lifts like squat are great. I think they're okay. I do them myself personally, but at the same time, would I have someone with a barbell on their back when they're experiencing knee pain? Probably not, because they're going to shift some of the load into the low back. I'd probably front load that a little bit more, such as a goblet squat, because it'll shift load into the hips. Or I will also too set them up with a target, such as a chair or a box. That way they have to shift the load back and sit them deep, tell them to sit deep into the box or chair. So those are just a couple ways to shift load. But again, 32, you're not old. I'm 38. I've had knee issues. And a lot of people I met have had knee issues, and it's surprising to see the people who are like, man, I'm just old. It's like, dude, you're like 36. Like, what are you talking about? And so it's, I know everyone's in different situations, but arthritis, at least osteo, is not strongly related to knee pain. And so that's a big myth that people have been hanging around for a long time. Okay, last question. I have Baker's cysts in both my knees. I have mild arthritis, but also 2 meniscectomies in one knee. What do I do to get rid of the cysts? Baker's cysts are out of my category. I'd love to say I have more information on that. There is one video I've created on the site for Baker's cysts, so I go on there, subscribe, and just Google Baker's cysts, because there's different types of cysts of the knee. Baker's cysts, though, they're generally kind of understood as a long-standing issue of the knee, and they show signs of things that have happened. It doesn't necessarily change. Ooh, you got a lot of questions now. So I think with Baker's cyst, I would go through and understand what Baker's cysts are on the page, because I think I go through a little bit more in detail than most people. But the approach doesn't necessarily change too much. Okay, last question. I apologize. This is going to be the last one. Jamie, we'll take this. I've been doing goblet squats and Bulgarian split squats as well. I've been trying to focus on, oh, you're the same person. Yeah. So there, I'll retract this one little bit. There's what I like to call first aid category exercises, which we show a lot on our videos. And there's also correctives, and then there's loading. Okay, think of it as steps 1, 2, and 3. A lot of people start at step 2. Step 2, actually, a regress set. Let's go 4 steps here. There's diagnosis and examination. There's first aid. There's correctives, and there's loading. Okay, so goblet squats, Bulgarian split squats, that's category 4. That's loading. I love when people are in category 4 loading. It's perfect. That's what I live in. That's what most people live in. And they shouldn't have symptoms with it. If they have symptoms, they have to scale back a little bit. Category 3 is corrective exercise. That's where a lot of people are kind of stuck in this no man's land of my therapist or chiropractor or trainer told me to do these banded exercises forever. And I just feel like it always comes back. The problem always comes back. And so again, regression into first aid. First aid is specific to the problem. There are things like end range loading knee, which we've covered in our on our page before. Just look up knee, which are very helpful. Or it's also not bad in these situations to have a knee brace, which is a perfectly adequate knee first aid. You take the extension out of the knee or the flexion out of the knee if it bothers it. So it's all dependent upon what the exam is, which brings us to step 1. Step 1 comes down to a good, thorough stress testing manual examination, not necessarily a image. Images are supplemental information and not necessarily needed to treat someone with a knee issue. So if someone has not put their hands on you when they've actually stress tested your knee, then you need to find someone who will do that stress testing for you. The videos on the knee, subscribe to our channel. There's a search bar at the top. You can type in whatever you want, including Baker's cyst. Okay, thanks guys for asking all the questions. It was great. I'll try to do these more often. If you want to be alerted when they're happening, just subscribe to the channel and turn on notifications. I'll try every couple weeks or so, if not more. But if I get more information, then if I get more information and I feel like things are going well, I might do them a little bit more often. So manual testing is key. People need to figure out what your body can tolerate, what loads you can tolerate. Imaging is great, but also it's supplemental. Talk to you guys soon. Make sure you go see your doctor.